Sorry for the delay. I can hear. I'm sorry for all the technology issues. There's been a delay in my joining the meeting, and let's make up for lost time and try to cover the subject. The topic I'm supposed to talk is absent pulmonary valve syndrome. And it also says quiz at the end of it, but I was a little surprised because I think we have had a talk on absent pulmonary valve syndrome, and therefore having a quiz directly was a little surprise. So I thought I'll just share some of the theoretical aspects, practical aspects of absent pulmonary valve syndrome, and maybe ask some questions on the way. Now, all are familiar with the classical tetralogy of Fallot, the most common cyanotic congenital heart disease we see in clinical practice. And that's also the fatal heart disease, which presents as the most common cause of cyanosis beyond 1 year of age. Not all tetralogies are classical. Classical in the sense where large subaortic VSD, infundibular stenosis, presenting cyanosis, so on. So there are some variants, and some of them are listed here. Neonatal TOF. Neonatal TOF appears to be a distinct variant where the pulmonary stenosis is often not so severe, it's often labile and so on. We won't discuss that in detail. Pulmonary atresia is a separate group. Some are acyanotic or pink Fallot, then tetralogy with ASD, which some people like to call it pentology. Tetralogy is a clinically distinct condition often associated with the aortic valve, aortic dilatation, aortic incompetence, and myocardial impairment, and so on. Therefore, TOF is often considered as a separate subset. Some of them are associated with absent pulmonary artery. I'm going to talk all about those variants. Interest in the last term, which forms about 3 to 5% of all tetralogy, called absent pulmonary valve syndrome. It's a very distinct syndrome. It was described for the first time more than 150 years ago. What it involves is absence of any functioning pulmonary valve tissue, not absence of anatomical tissue, absence of any functional pulmonary valve tissue. And usually the pulmonary leaflets and valve are reduced to small abnormal nodules on the ring of the pulmonary annulus. Therefore, there is no valve and it allows free pulmonary incompetence. It occurs as an isolated finding with no abnormality, but most commonly it occurs as part of other congenital heart disease, asyndromic or non-syndromic. The common variety which we see clinically is the atomy which looks like tetralogy of Fallot, but in addition has no pulmonary valve, no effective pulmonary valve, and therefore has associated pulmonary incompetence. Now let's anatomy here. I hope all of you can see this figure on the screen. Taken from one of the atlases. The right ventricle has been opened up to show the interior, and here you see the hypertrophied right ventricle. You see a ventricular septal defect with overriding aorta. As you come into the right ventricular outflow, you see that the infundibular septum has come anteriorly, which is for the large malign VSD. This is infundibular stenosis. But what different is tetralogy is there is no well-formed leaflet. You see in the nodular tissue here, the annulus is somewhat small. The most dramatic thing is the hugely dilated pulmonary arteries beyond the pulmonary valve. You see the main pulmonary artery, the left pulmonary artery, and the right pulmonary artery are all shown to be hugely dilated. Now, this is very uncommon and not characteristic of tetralogy of Fallot. Now, the basic anatomy is tetralogy. In addition, there is no effective pulmonary valve, and there is free pulmonary incompetence. There is massive pulmonary artery dilatation. Like tetralogy, quite a few of them, more than 10% of them, have the right aortic arch as shown here. Then the eventual hemodynamic abnormality depends upon the degree of pulmonary stenosis, the degree of pulmonary vascular resistance, and then it could be in the form of pulmonary incompetence, a combination of stenosis and pulmonary incompetence, or potentially pulmonary stenosis. Lastly, absent pulmonary valve syndrome has a combination of pulmonary stenosis and pulmonary incompetence. The pathophysiology of absent pulmonary valve. As I said, it's a combination of obstruction at the valvular and annular level. This does not offer any resistance. It's a etiology of failure in that there is anterior deviation of the infundibulous septum over right aorta and right ventricular hypertrophy. However, the hemodynamics are distinct. Predominantly a RV volume pressure overload combined. The clinical features are quite distinct as we'll see in the subsequent slides, and the outcome is distinct. It can occur in the absence of pathology and anatomy. It can occur isolated, and it can occur as part of other syndromes. For the associated syndrome, the discharge or the 22q microdeletion, it is the most common association with tetralogy-like situation. It has application because generally is associated with more complex pulmonary artery anomalies, either in the form of dilatations or in the form of stenosis. Also associated with many extracardiac problems such as hypocalcemia, deficiencies, parathyroid problems, and in later age groups it also involves some learning difficulties and higher incidence of psychological abnormalities in later age, and probably a higher incidence of dementia. Discharge syndrome, although it appears to be too severe at the onset, many more implications for the tetralogy of patients. The syndromes are velocardiofacial syndrome. We are familiar with multiple anomalies in the spine, knees, laryngotrachea, the face, and the most chromosomal anomalies, trisomies of 16, 18, occasionally with the hypoplastic right heart syndrome, hypoplastic parchment right ventricular use anomaly, or occasionally tricuspid reasoning. So we have seen patient who has pulmonary valve hypoplastic RV who went on to have spontaneous operation. Associated lesions. I've already mentioned, but pulmonary stenosis is not usually severe. It's usually relatively mild, and therefore cyanosis is not an important component. Absent ductal arteriosus. This is a very interesting finding in that the ductus, which is supposed to be present in all the fetus, is generally absent in these patients, and I'll discuss more of this in later slides. Other common associations are right aortic arch, muscular ventricular septal defect. Sometimes ventricular septum may be intact. Laparoscopic is tricuspid disease and right hypoplastic arteries. Now, one of the differences between tetralogy and absent pulmonary syndrome is the PR is often dominant, and therefore the right ventricular overload in the form of pressure and volume is a predominant feature. Therefore, clinical severity is often proportional to the degree of pulmonary incompetence, and as a result, the blood flow is not too much reduced. Silence is not very prominent. Hypoxia and spells are not an important feature. Child more of respiratory symptoms are serious. Tetralogy generally does not affect the fetus. Most patients with tetralogy and intrauterine life survive to term, and whatever levels they have are in the postnatal life. Now, absent pulmonary valve syndrome is one condition which causes severe prenatal hemodynamic failure. You know, the pulmonary vascular resistance is very high in the fetus. There's less than 10% of the cardiac output flows into the lung outside, and the big portion of the pulmonary blood flow is supposed to flow from the pulmonary artery into the aorta, the duct. From there it goes to the umbilical circulation. Now, in the presence of absent pulmonary valve, the resistance in the right ventricle is much lower than the resistance in the aorta. Therefore, if this is present, if the blood flow tends to leak backward from the aorta into the right ventricle. If that is not present, the blood tends to flow from right ventricle to pulmonary artery and back into the right ventricle through the absent pulmonary valve. Therefore, it causes significant hemodynamic problems to the fetal RV. It can cause high drop and fetal loss. More 50% of fetus with absent pulmonary valve syndrome do not survive term. Therefore, you see there's a marked difference in the incidence of absent pulmonary valve syndrome among live births. You see only about 0.3% of live births. When you study fetal autopsies, the incidence of absent pulmonary valve syndrome increases to about 1.5%, several times higher, indicating that we are not seeing all the patients, all the fetuses who have absent pulmonary valve syndrome because of fetal mortality. Anatomy is abnormal not only in the heart, it extends to the pulmonary artery branching as well. Shown on the left side is the normal branching pattern. The pulmonary artery divides dichotomously. That each artery divides into two, and then each branch divides into two. It follows a uniform pattern, and therefore you have a distinctly wide angle between each branch, which accommodates the airways. And when you look at the pulmonary branching pattern in absent pulmonary valve syndrome, you find that dichotomous branching pattern is not seen. The artery is often abnormal and tortuous, and then ends into a tuft of branches, which all parallel in a parallel fashion into the alveoli. Therefore, there is hardly a space between the two branches of the pulmonary artery, which surround the small airways and often cause compression of the small airways. Therefore, airway compression at two levels in absent pulmonary syndrome. One, a hugely dilated pulmonary artery, which compresses the left main bronchus or the left main bronchus or sometimes the lower trachea. You have the pulmonary obstruction in the airway due to abnormal branching pattern in the pulmonary artery, a leash-like branching pattern which surrounds the small airways and causes compression, and you have obstruction at the intrapulmonary airway level. Issues are as important as cardiac issues. In fact, most of the infants, issues are often more predominant as compared to the cardiac issues. It's a major problem in the neonatal phase because there you have small airways, weak airways because the cartilages are not developed, poor respiratory muscle effort, also because the pulmonary incompetence itself causes a large pulsatile load on the pulmonary, which causes airway compression. Associated laryngomalacia complicates the issue. Large airway compression by neuromuscular proximal pulmonary artery, small airway compression with abnormal PA branches. The combination of air trapping, attenuation of segment, emphysema, pneumothorax because of high alveolar pressure, using stridor, severe respiratory distress, are often leading to ventilated. Now, whenever the airway is compressed and not developed normally, especially a young infant, this is accompanied by malacia and poor development of the cartilages, and therefore this remains a problem even after you are successfully repaired. So therefore, considering the hemodynamics and the associated problems in absent pulmonary valve syndrome, present in 3 or 4 distinct clinical groups. The first group is a fetal group. Fetal group we hardly ever see. Only fetal specialists may be saying it on ultrasound studies, and most of them are lost before delivery. Only about 50% reach term. So that's fetal group. The second one is a neonatal group where the respiratory symptoms predominate, where airway compression and pulmonary complication, a lot of element of heart failure because of RV volume overflow. Finally, if present, it's probably due to the respiratory component. You have hypoxia due to ventilation, poor air, air exchange, and secretions, collapse, and so on. If they survive the neonatal period, and the mortality in the neonatal period is quite high, of all patients with absent pulmonary syndrome who are born, 40 to 50% of them die in infants. then 50% survive in country. These patients are relatively stable. No, stable not because of our treatment, because they have been naturally selected. They have the naturally better set of patients who probably have less degree of airway compression, who probably have stronger airways which can withstand compression. They have survived the initial turbulent phase of the fetus and initial other turbulent phase of the immediate postnatal period. These are relatively stable patients, and they are the patients who are picked up by most of our clinics and often survive for the next 1 to 2 decades. They are diagnosed because somebody noticed that they are cynos or the prominent heart murmur. I'll come to the heart murmur in a little later. But then the combination of stenosis, incompetence, and hypoxia eventually causes heart failure. Therefore, these patients survive for 2 decades. They with a combination of cyanosis and right ventricular failure, and the other group of pulmonary absent pulmonary embolism. Therefore, we have a fetal group, neonatal group predominantly respiratory problems. We have a relatively stable group presenting because of a chronic heart murmurs. And finally, we have a other group which presents with right ventricular failure. 4 distinct clinical groups, and we will be able to identify it. In clinical practice, the most common form we see is the third one, the relatively stable 2 and 4 group. Because patients die between second to decade and may not be seen in pediatric cardiology. The hallmark of the stable group is relatively mild cyanosis. Often cyanosis is missed. Clubbing may not even be noticed. And they have prominent to and fro murmurs. I wonder how many of you have heard that Fallot absent pulmonary syndrome have a very distinct to and fro murmur. The very distinct, unmistakable cardiac auscultative finding, and we have very few conditions which can mimic the to and fro murmur in congenital heart disease. Now, pulmonary competence murmur can be understood better if you study this diagram. Now, I hope you are familiar with all of you are familiar with this diagram. This is what is called a Bigger's cycle diagram, which depicts all the cardiac events in graphic form, and you are able to time each event along with the ECG. I won't go into details of the pulmonary, all the events in the Bigger's diagram, but here I can tell you the diastole. The diastole starts with the second sound. The second sound is made up of 2 components, A2 and of a short interval P2. Now, the pulmonary component can start only after P2. It often increases in intensity towards mid-diastole, then subside towards late diastole. So it's a diamond-shaped murmur. It on slightly later onset after the A2. Its increases and crescendo decreases in character. Low-pitched murmur, because the first the lungs are not very high, and so it is a low-pitched murmur. It's often called a low-pitched rumbling murmur. And people start sometime after A2, people actually like to call it mid-diastolic murmur rather than early diastolic murmur. Speaking, it is starting with the second sound of the program, but since start after the A2, some people actually describe it as a mid-diastolic murmur. So it's actually described as a diamond-shaped crescendo decrescendo, low-pitched rumbling, mid-diastolic or a mid-diastolic murmur. Okay? It is distinct from the aortic incompetent murmur. Aortic incompetent murmur is often a high-pitched murmur. High-pitched. That type of high-pitched murmur. Often it's a decrescendo. It doesn't show a crescendo decrescendo quality. It starts immediately after A2 here, and then it gradually subsides. The more early diastolic high decrescendo murmur is AR. It must start sometime after A2 or mid-diastolic. Decrescendo murmur is often called a diastolic murmur of low-pitched pulmonary incompetence. Okay. Now, there is pulmonary hypertension and you have pulmonary incompetence. That murmur will exactly be resembling AR murmur. That is, you will be very close to A2 in pulmonary hypertension. Start at will be decreased like this. So the difference between aortic incompetence murmur and hypertensive PR murmur. But the normal PA pressure PR murmur is very distinct. Doctors operated etiology of Fallot also have similar murmur. Low pitch, low pressure PR murmur. There are causes of to and fro murmur which you must know from the exam point of view. VSD with aortic incompetence. In this case, you have a systolic murmur of VSD and a diastolic murmur of aortic incompetence. But incompetence is very distinct, high pitch, early systolic, deep murmur. So, truncus arteriosus, it's an equivalent of aortic incompetence, therefore, high pitch, early diastolic, deep murmur. Diagnostic pulmonary valve, that is, like Raghavan syndrome, may have pulmonary incompetence, which has a low pitch PR murmur, similar to absent pulmonary valve. But then diagnostic pulmonary valve is often asymptomatic. The features of Raghavan syndrome in the face, in the skeleton. And the TPVC often causes a systolic murmur in the upper left bone. Also can cause a flow murmur. In tricuspid valve, it can cause flow murmur in the vertical vein. Therefore, a combination of systolic and the diastolic flow murmur, it resembles the to and fro murmur of pulmonary valve syndrome. The characteristic of the sound, which is wide and fixed switch and TAPVC, and the key features of airway compression differentiated. Anomaly is another anomaly which can cause mild cyanosis, it can cause systolic and diastolic murmur as well as cloud murmur. But again, clinical features, clinical presentation, the more presentation is distinct. Now, continuous murmurs in the upper left arm border can always be mistaken for to and fro murmur. So, you must be careful to exclude these conditions if diagnosing pulmonary valve. But by and large, the to and fro murmur is very, very distinct here, and there should be no major issue in making the diagnosis. The usual tools are available for working up, but I'll just go through some of them which are particularly useful. Of course, echocardiography is the anchor, but also as in congenital heart disease, and I'll show you what distinctive features are. Other imaging methods have become very useful in recent times to produce more detail. Of course, a major part of evaluation is devoted to the lungs. After evaluate how severe the pulmonary functions are affected, how severe the bronchi are affected, and how far the trachea and bronchial trees require transplant and treatment. So the incidence of respiratory distress and aspiration, inhalation, and clear reflux, which need associated workup and management. Many of patients have 22q deletion and other syndrome, and therefore it might be worth doing genetic evaluation, which helps to prognosticate the patient if we do not use it in the management of the case. This probably is the first clue to a pulmonary valve syndrome. What is the X-ray? It shows a cardiac fillet, which is classical for tetrahedral, a boot-shaped heart. My cardiomegaly, a rounded apex which is lifted up from the diaphragm, indicating right ventricular side. Concave pulmonary artery segment here. Relatively dark or oligomeric field. You don't see any branches of pulmonary artery in the peripheral one-third of the lung. What is usual, you see two large shadows in the right hilum and the left hilum, and if you carefully, the right hilar shadow appears to be the right pulmonary artery because tapering down towards the right lower lobe. It's a dilated right pulmonary artery paper, and this also steps down towards the left lower lobe, indicating probably the left pulmonary. So this is an unusual case of a pathology like Fallot with massively dilated RP and LPA, which are attention to the possibility of absent pulmonary valve syndrome. So this is not a picture of classical tetrahedral. Therefore, we must suspect suspect absent pulmonary valve syndrome, clearly these patients almost certainly have to and fro murmurs at the left hand bottom. So that's right. Now when you do echo, you have certain differences from the etiology of Fallot. Here you see parasternal short axis, where the right ventricle is dilated, normally in the etiology of Fallot, and very hypertrophic ventricle, and while the infundibular septum deviated into the RVOT causing narrow. Here also the infundibular septum slightly deviated, but stenosis is not very severe. In fact, the right ventricular outflow appears to be dilated. The axis is somewhat small, but you don't see any clear leaflet. You see nodules of tissue on the you do not see any leaflet span. And unlike classical tetralogy, you find fully dilated RPM and LPM. So, in other views which show a classical subaortic VSD with overriding aorta. Therefore, subaortic VSD overriding aorta along with annular stenosis, not pulmonary tissue and dilated pulmonary artery is predictive of pulmonary valve syndrome. Calculation helps to identify pulmonary incompetence. Depending on the degree of pulmonary incompetence, you find a moderate in the right ventricular outflow, or you can have torrential pulmonary incompetence, filling up the entire right ventricle. Active pulmonary incompetence as shown here. You have a moderate gradient of ranging around 30 to 60 millimeters in systole, and the predominant hemodynamic problem being pulmonary incompetence. You could have variations in the chest X-ray. You could have the asymmetry in the dilation of the pulmonary artery. Here, you find a patient with asthma in which it appears to be directed towards the left pulmonary artery, and therefore you have massive unusual dilatation of the left pulmonary artery. The right pulmonary artery does not appear to be dilated. Here is another patient where you have massive dilatation of the right pulmonary artery and a lesser degree of left pulmonary artery. Now, you can the arteries are tapering the periphery, but they don't appear to be pruned. You can in fact trace the pulmonary artery easily right to the periphery of the lung. Then, although the proximal pulmonary arteries are large, there are two major differences from the pruned and the pulmonary hypertension. The pulmonary artery is not dilated. And the branches are not cut off. You can trace the pulmonary arteries all the way to the periphery, gradual reduction in amount. Only the hilar pulmonary arteries are dilated due to the pulmonary incompetence. Here are a few X-rays which are not absent pulmonary valve syndrome, which mimic an X-ray of absent pulmonary valve syndrome. So let's consider them one by one and see what are the differences. Here you have a patient who has cardiomegaly, some of these pulmonary vasculature, and a large shadow in the superior medial canal extending on both sides. This could be taken for dilated pulmonary arteries. We will see the main pulmonary artery and RV outflow are prominent. This, along with the increased pulmonary pressure, indicates that the pulmonary vasculature will increase. And this more in the superior medial canal. Then, idea what this is? Yes, anybody? So, what is called a supracardiac snowman's appearance or supracardiac TAPV. Here, one component snowman sitting here, another component of snowman sitting here. It's a appearance. Okay. Supracardiac TAPV. Okay. So here another X-ray which mimics dilated pulmonary artery. The case of swelling is predominantly in the upper medial channel. Asymmetric. Right is somewhat rounded. The left side is more angular. It's triangular and then forms a different geometrical shape here. The vasculature appears relatively normal. So with sharp angulations like this and asymmetrical pulse is and the severe sternum in an infant, think of thymus. Vasculature, white pyramidal sternum, relatively stable patient, think of prominent thymus. Here, the super 8 figure of 8 appearance of PVC. This is the precardial thymus. Here, the patient where hilar arteries are very, very prominent. Therefore, yes, you can take an absent pulmonary valve, but the difference is these are the main arteries. Vein pulmonary is dilated. In fact, it is bulbous. So, this pruning of the pulmonary artery immediately after the dilated branch. Yes, I agree. It's by Eisenmenger. Immediately after the dilated pulmonary artery, you have pruning and you hardly have any vessels in the periphery. Therefore, dilated proximal pulmonary artery, dilated hilar pulmonary artery, and cut off peripheral vessels indicate Eisenmenger. There is no picture of dilated pulmonary artery and absent pulmonary artery. Finally, here is fine. Picture in which the cardiac fillet looks like tetralogy of Fallot, concave pulmonary artery segment, configuration oligemic lung. There is something in the right upper cardiac wall here. Could it be the RP? Very unlikely, because this is going much above the clavicle into the cervical. Very strange. I agree. I agree with your diagnosis. It's right aortic arch. Can you see the aorta indenting the trachea on the right side? And you can see the descending thoracic aorta on the right side. Here. I suppose the right SPC is pushed further to the right. They're all right. The etiology with the right aortic arch on the right and the SPC being prominent on the right side. These are all X-rays which can mimic absent pulmonary valve syndrome. Supracardiac PVC. This thing is here. It is figure 8 appearance with the thorax and OT main pulmonary artery. Thymus is relatively normal heart and normal vasculature. Prominent main pulmonary artery and prone due to Eisenmenger. It is right aortic arch and urina and side bulging. Look at absent pulmonary valve syndrome again to understand the difference. How it is distinctly different. We see arteries in both the hilum, but it often tapers down into the lower lobe and the branches into the periphery. Right. Here is another X-ray in the neonate, which people have mistaken for absent pulmonary valve syndrome. It's a huge heart. As the concave pulmonary artery segment moves somewhat like it's Fallot, and there is oligemic lungs. So, could they absent pulmonary valve syndrome? No. Absent valve syndrome does not generally have marked oligemia of the lung. The person is never that severe. Oligemia is not an important feature of absent pulmonary. In fact, very often it is mistaken for plethora. The hilar arteries are big, the bodies are show hyperkinetic pulsation, and you often see buildup of pulmonary plethora. I think of oligemia is unlikely. If you have cardiomegaly, is unlikely. This shows 90% CTR. There's a huge thing. Now, what this is? What is hypoplastic? You say hypoplastic left heart syndrome? You say huge syndrome. Okay. Yes. It's a form of severe tricuspid incompetence. Yes. A form of severe tricuspid incompetence. For example, huge anomaly, yes. Or it will be pulmonary atresia with the intact ventricular septum. The more massive heart sizes with ischemia are seen in pulmonary atresia with intact septum and hypoplastic right heart syndrome. That is a small RV or a parchment RV like huge anomaly. So this massive RA cardiomegaly concave pulmonary segment typically occurs in hypoplastic RV. So these have given me some X-rays. Particle absent pulmonary syndrome, some X-rays out. Now we have your imaging modalities which you are all familiar. You must have seen examples of all these. Therefore, I don't intend to discuss it in detail. CT or magnetic resonance imaging both are great, Here I show you a few pictures which actually show the intracardiac anatomy as well as the pulmonary artery dilatation. You see the VSD, the right ventricle, very obstruction in the infundibular level, although the infundibular septum is distinctly deviated anteriorly, producing a malaligned VSD here. The ventricle is here small with the dysplastic valve. You don't see the doming pulmonary valve. You see a massively dilated pulmonary valve descends into the branch PS. In the horizontal section of the chest, you see what's like a short axis view of the echo. You see the two branches of the RPA and LPA with massive dilatation, much bigger than the accompanied aorta. This abnormal branching pattern of the branch ends in a tuft of parallel unlike normal diatomic branch. You can see how this massively dilated RPA and LPA can actually compress the trachea and the right bronchus and the left bronchus. Two examples of more huge dilatation to the RPA, which is stretching out and make the right bronchus into a narrow, flat passage. And here you hardly see the right bronchus. So, causes of significant compression and pulmonary problems in the right lung. The newer methods of 3D proven reconstructions give you more pictures, although whether it adds any new information, traditional views is doubtful. You see relatively mild infundibular obstruction, a small annulus, no valve leaf, mass dilatation of main pulmonary artery. To compare either pulmonary artery with the aorta, which is much smaller. Okay, this is shown from the posterior aspect, and therefore we see this side and this is the right side. To sagittal, you could see how the right bronchus is actually strung out like a thin wire on this area of the pulmonary artery. As a human, and it becomes worse during certain phases of respiration. This often causes difficulty in air entry, but we are difficult in air exit, and therefore air trapping and problems in these segments are quite common. Therefore, we identify the degree of hyperplasia of the right bronchus, the degree of stenosis, and areas which require special attention, like stenosis or relation. Yes. Can anybody tell me what this picture shows? Yes. Labeled. Okay. It's a now, again, pulmonary syndrome is one of the important causes of fetal demise. More than 50% of absent pulmonary syndrome do not survive the uterine. And therefore, identifying it in intrauterine life is very important. You're planning to develop some treatment for the fetus. But more often, you identify those children who require special care immediately after birth. And that's important. So you know that the baby is going to be born with absent pulmonary syndrome. You should show that the child is born in a hospital care. You can handle respiratory and cardiac issues. The prenatal diagnosis equally is very important. And it's fairly easy to pick up absent pulmonary syndrome in the fetus after the 16th or 18th week, because the pulmonary branches are abnormally dilated. It's quite to identify the RPA and LPA. Very often the pulmonary arteries are bigger than the heart itself. Therefore, if you see very dilated pulmonary arteries, and you should suspect it. Now, similarly, this shows more after pulmonary syndrome, when you aorta, you can see the right pulmonary artery in its concavity. You see the disparity in size between the pulmonary artery and the aorta. When you mark disparity, you must look further into the right ventricle, identify the right ventricle outflow, and very often you will find the pulmonary valve is not there. You could have fetal echoes clearly showing pulmonary incompetence. You show the left ventricle is often less than the left ventricle. You have accompanying right incompetence and therefore dilated artery. Therefore, fetal echo is an important component of diagnosis in acute pulmonary syndrome. Include dilated pulmonary arteries. Relatively large size PA in relation to the size of the aorta. And dilation of the right ventricle, dilatation of the right atrium, for evidence of pulmonary incompetence. Okay? The subaortic BSD with overriding is very easily picked up after this 8 week of gestation, and therefore, presence of BSD, if you see markedly dilated pulmonary artery, Doppler evidence of pulmonary incompetence, and diagnosis of acute pulmonary valve failure in the fetus. Delivery in a proper place and proper management. And instead, the findings are those of tetralogy, easily identified, and usually large branches. Is important too. For these babies who have intrauterine dilatation, you study them soon after birth, you often see massively dilated pulmonary arteries like this, and this is often called the Crover sign. If you Crover in the playing card sign, you have 3 bulges. The 3 bulges are right pulmonary artery, left pulmonary artery, and the third one is the right ventricle. So you identify a Crover sign either in an angiogram, or a CT angiogram, or in the MR angiogram, or an echocardiogram. Doesn't have in which. If you see a prominent Crover sign, it indicates severe pulmonary valve syndrome. Marked disparity between the pulmonary artery and the distal pulmonary artery. Normal branching pattern. Intrapulmonary arteries are not dilated, and therefore you have a combination of a large volume overload here, relatively high resistance in the abnormal small pulmonary artery branches here. So the Crover sign. The Crover is a diagnostic sign in pulmonary valve syndrome. When baby is seen soon after birth, the X-ray looks like cardiac enlargement. The X-ray often looks hazy. It could be mistaken for hyaline membrane disease. It could be mistaken for obstructive TAPV. And because the pulmonary are not very clear, the lungs may look edematic, and it would be a combination of tachypnea, secretion, distress, and also in these cases may often due to the accompanying lung problems. See, they can like to see the air happening and poor movement and so on. So this X-ray diagnostic, it could mimic many other conditions and but definitely once you have an abnormal cardiac cellage and a healthy lung, it's for echocardiogram to rule out a significant kind of problem. Also, this shows actually driver curve and the one which is marked blue is called pulmonary. Very technically with classical pulmonary stenosis. Obviously, that is the best category. There is a small subgroup of pathologies who are severe forms who are high mortality in the first year of life or first few months of life. But after almost 70 to 80% survive in the first 1 year of age, or 30% survive to 5 years of age. And then there is a gradual mortality, and by the age of about 40, 55% or 90% of them have died. This also shows mortality only in the first 10 years. But international studies are available up to 6 years of age, where the mortality continues to decrease, and therefore you very attrition. And after the age of 40 or 45, relatively compromised in 5% of cases. You have to see a 60-year-old man with pathology of Fallot. Therefore, that is promising. They have relatively good survival in the earlier part of the life. Now, somebody atresia, it's a different ballgame. They were much higher. About 20% of patients survive the first year of age, and even by the 5 or 6 years, about 85% have died. About 15% are beyond the first decade, and by the fourth or the fifth decade, less than 5% or less than 3% are alive. Therefore, we have the best survival, and pulmonary has a much lower survival. The acute pulmonary syndrome is a really bad condition. It's more like pulmonary. So the degree of this stenosis is not that severe. We have mortality in the first few months of life, mainly because of the associated like airway problem in the lungs and the brain heart failure. It drops deeply in the first few months of life and continues to drop. So 70% are dead in the first year of life, and again gradually decrease survival until age of 40 or 50 when less than 5% are alive. Therefore, message from this slide is what kind of pathology you have. The survival after 40 is quite less. From the earlier part of the natural history, classical pathology seem to have a better survival than absent pulmonary syndrome and pulmonary. So, poor survival in absent pulmonary syndrome indicate that intervention is definitely necessary. Irrespective of whether the patient has symptoms or not, the patient is likely to have a downhill course or follow-up. Therefore, treatment is certainly necessary in option with absent pulmonary syndrome. So, what does initial management consist of? The management, of course, after the airway. I don't need to go into the details of this. Better off in the prone position, because when you put the patient prone, you actually the pulmonary arteries in the heart falls out from the bronchi and the tracheal bifurcation. Therefore, the degree of airway obstruction is much better in the prone position and the head-up position. Head-up helps to facilitate the diaphragm movement, so it makes air movement easy. Also, lead ventilation, and ventilation in these cases is a very scientific check, tightly adjusted, especially the degree of peak. There are often requirement for relatively high peak to keep the airway open, and therefore it requires an expert intensivist if you have a patient with absent pulmonary syndrome. And the aim is to always stabilize the patient and work up towards surgery. The objective of treatment in absent pulmonary syndrome is to correct the pulmonary function. And surgery is required. Repair technology like technology that is to the BSC, restrain fundamental, relieve any degree of obstruction, and put a valve or a valve conduit to prevent pulmonary function. Now, that obviously improves condition of many patients, and there's considerable experience in doing absent pulmonary syndrome repair. However, this is not enough, and colored in that few slides. A few studies which have shown the late results of absent pulmonary syndrome, and summarize a couple of them here. In a very long-term study, almost 38 years follow-up experience of 52 patients operated for absent pulmonary syndrome. This is from the Boston Children's Hospital and published in 2014 and thoracic surgery. Now, this survival for about 30 years are the correct. Now, one thing you must remember that these were all operated in the 70s and 80s. All these patients were operated in between 1 year to 5 and 15 years. They are the very selected good steps of natural absent pulmonary syndrome. The ones bad risk, bad anatomy have already died. So this represents the outcome. Only good risk patients who survive long enough to have surgery. They are naturally selected to be survivors. They are survivors among all the pulmonary syndrome because many of them died in fetal life, many of them died in the first few months of life. If they died, then they have surgery. So this is good risk surgery. So even if you have a certain amount of cost immediately at surgery, and then a relatively stable period of 10 to 20 years, but later this attrition starts often because of development of right ventricular failure, and the fact that up to about 50% of all those operations at 25 years. So even if they are the good risk category, their survival usually at 20 to 20 years. Survival is used because of chronic changes in the right ventricle and right ventricular failure. Now that freedom from reoperation. Freedom of operation means because conduit has been placed, which is an artificial valve, has to be replaced at time. Sometimes they do need reoperation for tricuspid incompetence and associated lesions. Therefore, this is the survival of the surgery, and this is among survivors, the operation-free survival. At the age of 10 years, only about 50% are free of operation. Another free of operation. So, after conversion, after return, continue these lifelong follow-up and after. Experience because after conversion syndrome should be operated earlier. These are operated after infancy, and therefore it is felt that they should be operated much earlier than this. And the current concept is to operate them before they develop aortic dysfunction. And this is a more recent paper which showed the outcome in pulmonary syndrome from the Institute of Medical Sciences. They had a total of about 40 cases published in Ninaja in 2017, and it was survival over of about 8 years survival, and after surgery, the survival in the first 10 years is among hospital survivors. The surgery is fairly good. The recent survival. The patients have been operated earlier. Unoperated infants with Diagnostic value have a very high mortality on a follow-up of 5 to 10 years. Determinants of outcome. Age. Obviously, age is associated with immature airways. The ears are small, they do not have adequate cartilages, they are not strong enough to bear the compression, and degree of micromalaysia is high. Therefore, lower age and lower weight typically has bad survival. As in the other patients, the right ventricular function and accompanying tricuspid incompetence is determinant of outcome. Why does the pulmonary dilate in absent pulmonary? This is an interesting topic. Just discuss for 2 or 3 slides on this. Many factors have been proposed. One is a large volume renal tissue. Like the dilates in aortic incompetence, dilates in pulmonary incompetence. But the surprising thing is there are other conditions in pulmonary incompetence in which the pulmonary artery does not dilate so much. So other people have postulated, just like in bicuspid aortic valve, the aorta degenerates in the media. So there may be some degree of degeneration, but only a hypothesis has never been proved. Now, one of the most important things, the absence of PD. When better arteriosus helps to deepen the pulmonary artery into the descending aorta in the fetus. If the fetus is absent, you have an absent pulmonary vein, the blood flow from the to PA and back into artery. If a blood flow movement without compression through the ductus was dilatation of the main pulmonary artery. So, for the major cause of PA dilatation, be the absence of PDA rather than the other way around. Of course, the resistance in intrapulmonary circulation is always high in the fetus and the neonatal life. So, all contribute to the dilatation of PA. Particularly in the intrauterine life, the ductus arteriosus may be an important factor. The role of patent ductus arteriosus. Many people have attributed absent pulmonary syndrome to absent ductus. They say ductus is absent, therefore pulmonary artery is unable to decompress, therefore the pulmonary valve regurgitates into the artery. But usually in absent pulmonary syndrome, the patent ductus is not seen. However, really when you see the ductus in absent pulmonary syndrome, you find that the pulmonary dilatation is much less pronounced. So many people think that absent ductus is really a positive factor in the case. That is, ductus is absent in a patient with absent pulmonary syndrome, where valve is dilated. So there is a new concept of circular shunt in absent pulmonary syndrome. Let me explain to you what pulmonary valve and when you have ductus is you have ductus that leads from aorta into the pulmonary artery. Pulmonary artery, due to the pulmonary component, leaks into the artery. From the artery, it goes through ESD into the LV. From the LV, it goes to the aorta. From the aorta, through the duct, again it comes back into the pulmonary artery. There it's a lot of circular shunt in the fetus. You understand? Ductus, incompetence, VSD, aorta. Again, ductus, pulmonary incompetence, VSD, aorta. Incompetence, VSD, and aorta. So it's non-stop circular shunt continues throughout fetal life. Therefore, non-stop circular shunt in a fetus with massive RV volume overload. The circular shunt is depicted. From the descending aorta, ductus, the PA, PRV, VSD, LV, aorta, back to the ductus. Massive shunt into the right ventricle. Therefore, many of these patients do not suffer. A significant runoff occurs from descending aorta to the right ventricle. When there is significant runoff, there is a volume overload for the fetus, develop fetal hydra. On top of it, there is steel from the aorta. Therefore, the more important organs in the body do not get adequate perfusion, and therefore there is steel. Excessive circular shunt in such fetus do not survive. Not see those fetuses. Therefore, it is that among fetus with absent pulmonary syndrome, one with absent PDA will survive term. So PDA has nothing to do with the absent pulmonary syndrome occurrence. Pulmonary syndrome is a genetic anomaly which the pulmonary has to be undergone. In this, if a PDA is present, a fetus dies. Absent pulmonary syndrome and the fetus does not have a PDA. The body dilates, but the patient survives. There is no circular shunt. So the PDA in pulmonary syndrome is a little confusing. Whether it's protective or whether it's causative. An interesting concept of circular shunt. There are a few other cases. Example in congenital heart disease is called circular shunt. And in fact, once upon a time there was a short note in the session on circular shunt. It's an exercise for you guys. Look up causes of circular shunt in the heart, in the congenital heart disease, and discuss what are the causes of circular shunt and its clinical manifestation. I'm going to discuss. And guess what this image shows? I'll give you 30 seconds. All have seen this with MR imaging, but I'm sure you would have seen it on echo also. Short axis. eye section. What about this? No? Okay. The PA bifurcation lies behind the aorta, isn't it? This is anterior, this is forward, this is forward, this is posterior. A short axis orientation. This is anterior, and not this bifurcation should lie behind the aorta here. Okay. Here the bifurcation in front of the aorta. So what's it called? Lecomte maneuver. The Lecomte maneuver. The surgeon puts the right pulmonary artery and the bifurcation anterior to the aorta. And maneuver is most known in transposition arterial switch operations. The surgeon often brings the pulmonary bifurcation and RPA anterior to the aorta to prevent airway compression and keep the pulmonary artery. Now, the Lecomte maneuver is often used. So this is to compare with a normal echocardiogram. Can you see the difference? Here, the anterior you see the RVOT, and you see bifurcation behind the aorta, and RPA is behind the aorta. This is normal echo. Whereas after Lecomte maneuver, the bifurcation is anterior to the aorta, and RPA is anterior to the aorta. This is the Lecomte maneuver. We can use in absence syndrome. In T, it is used to prevent kinking of pulmonary arteries. This is what Lecomte maneuver is. This is a normal line. The pulmonary artery goes from front to the back and divides into two. The RPA crosses behind the aorta. In the maneuver, they cut the aorta, bring the RPA in front of the aorta, and reconstruct it. So pulmonary artery bifurcation lies in front of the aorta. Okay. So the Lecomte maneuver, which is very useful to take the pressure of the right bronchus and then carina. So the carina and the right bronchus. After Lecomte maneuver, the pulmonary artery is taken off from carina and the right bronchus. So this is Lecomte maneuver. So management of airway involved. Sometimes you do PA plasty, that is a huge available dilated pulmonary artery to reduce the pulmonary artery extra tissue and reduce the pulmonary artery. Second, combined with often Lecomte maneuver, where you bring pulmonary artery bifurcation and the right pulmonary artery in front of the ascending aorta. Finally, more recently, expandable stents, the bronchial and tracheal stents are being used in order to big airway patent in Aspen pulmonary syndrome. Okay, so management of Aspen pulmonary syndrome involves stabilization with ventilation and respiratory management, identification of genetic and other accompanying aggravating factors, modulized for corrective radiographic incompetence, BST. One pulmonary incompetence and BST, you have to attend at the same time to the airway issue, reduce the pulmonary artery size, bring the pulmonary artery anteriorly and to the aorta so that to ensure the Lecomte maneuver prevents airway obstruction. And in later follow-up, you have to keep the airway patent, especially with trachea, bronchomalacia. You have to refer to the ENT person to consider either or stents for tracheal and bronchial narrow. So, and that brings me to the end of my talk. Thank you very much for your patient hearing. I'm afraid there's not much time for discussion already. After 9, I'd be very willing to answer any queries you have on this talk. If you want to send me an email, I hope you have my email ID. I'll just you can write to me at cardio